Hey everybody, it's Friday again. That means the Doctor's In Live with TOA is in the house. Hope you guys are doing well. I'm Stahlman, I'm your host. As always, I hope this information is of value to you, it's of interest to you. Remember that all the information we talk about today is for your information and educational and a little bit of entertainment purposes only. Dr. Carpenter and I are both physicians, but we're not your physicians, so please don't take this as medical advice. We have a really interesting topic today, something that frankly I know very little about because I trained a long time ago. This is Dr. Will Carpenter. He's one of our newer physicians with TOA, and he's a total joint replacement physician. And you can see all this stuff around us. He's actually going to talk about some of the modern technology that we use in joint replacement. It's really come a long way since when I trained. I mean, he doesn't even know how I trained. He has all the bells and whistles. So to that end, we'll talk about that. Again, TOA.com, that'll be your resource for any type of information about Tennessee Orthopedic Alliance. We're the biggest, largest, oldest orthopedic surgery group in Middle Tennessee, and we cover all specialties except for orthopedic oncology. And if you have any needs in the musculoskeletal world for yourself, family members, etc., go to TOA.com. You can find information about our physicians, about our services, about our offices. We are open. We are, however, following CDC and state guidelines regarding wearing a mask, social distancing, taking temperatures and health information. We're modifying our intake process into the offices to minimize the chance of spreading COVID-19 or any other bad stuff to one another. So please understand that the steps we're taking are for your benefit, for your health. We're trying to keep you from getting sick, and we would appreciate the same type of consideration. Anyway, without further ado, I'd like to introduce Dr. Will Carpenter. Thanks, Will, for coming. I appreciate it. Do me a favor. Tell us a little bit about you, your training and whatnot, what your interests are.
Well, thanks for having me on today. A little bit about me. I'm from Waco, Texas, and I went to Auburn University for undergrad. Now, it's tough to say around these parts, but I went back to University of Texas for medical school, and then I lived in Atlanta for 5 years where I did an orthopedic surgery residency at Emory University. And then I traveled up north to New York City where I was at NYU and the Ensol Scott Kelly Institute, where I did a one-year fellowship in adult reconstruction. And I had a lot of exposure to some of the upcoming and new technology that's out on the market today, and that kind of sparked my interest in this. And I'm glad I could bring some of it back down to the South and be able to use some of these new innovations on some of our joint replacements.
Well, we love having a Southern boy coming back to the South. You mentioned adult reconstruction. Now, really, that's more to narrow the universe, joint replacement.
Right.
And you concentrate on hips, knees. Do you do other body parts, shoulders, ankles, elbows, anything like that?
It's mainly hip and knee replacements, and then also complex hip and knee primary and revision or redo surgeries.
Okay. Okay. So do me a favor. We got all this stuff here. What are we looking at? What is this?
Right. So what we have here, this is a robot, and in layman's terms, but this is the Mako system or robotic-assisted total knee replacement. And some of the technology, we're going to be talking about this today, but in broad terms, when you talk about technology and joint replacements, and there's a lot going on right now. It's very exciting times, and the way I think about it is in two different ways. The first way is you have computer navigation, computer-navigated total hip or knee replacement, and then you have a robotic hip or knee replacement. So with computer navigation, what that means is you have a handheld device. It's almost like a handheld computer. And whenever you're in the operating room, the surgeon has this computer, and it gives you more information about a patient's anatomy and also helps assist with component positioning, meaning that the acetabulum or the shell, whenever you're doing a hip replacement, you're able to actually see where it is in the patient's body and in space, so that you can provide the best implant positioning. Okay, this doesn't actually perform the surgery or anything like that. It's all it is giving data. Okay, when you talk about robotics is a different story here. With robotic surgery, especially in hip and knees, you are actually getting a anatomic 3D model of the patient's hip or knee. Okay, you're using this model to help with precise implant positioning, and then you're also using the robot, which we have here on the left here, and we'll go through this in just a second. But we're actually using that to execute the preoperative plan with very, very accurate and precise planning. So you're able to execute what you plan to a very, very specific part. So it's very accurate, and it doesn't deviate very much at all.
So tell me, what's the point of navigation and robotic surgery? You mentioned on both of those, kind of the big deal is accurate implant placement. What are you trying to get from that other than a perfect picture? What do we hope to see?
Yeah. So we know from research and years of looking at this that when an implant is in the correct position, there's a less chance that you're going to have to fix it later on. So there's a less chance that it's going to become loose. Or they're in a hip replacement, there's a less chance that you're going to have instability, which just means that less of a chance of a dislocation or your hip pops out. We know that implant position correlates with decreased risk of revision.
And that's something I think that's really, that science, that knowledge base has really changed over time. Because when I trained, everything was done by eyeball. There was crude positioning. We didn't really understand the 3D biomechanical, mathematical alignments. This is where algebra, geometry come into play, of the forces of the body on the implant. And that's where I think over time, changes in that information, changes in the technology, and hopefully, as I gather in talking to you before this, as the future unfolds, this type of technology will prove out that the more accurate you can be, the less likely it is that you're going to have a preventable complication, such as dislocation or instability, and hopefully we'll see longer life of the implant, meaning you don't have to redo something because of a loosening problem or something like that. Is that right?
Correct. And historically, we've always shot for a target number. There's a range for putting the shell, where you're putting it in space or what you're looking for in a knee. Now we're actually shooting for numbers. And with the numbers, it's more accurate and more precise, and we're able to achieve that very successfully with using this robotic system or with computer navigation.
And with the technologies, it references the body part. So the body part can be in any position, and you still have an accurate representation. In the historical way of looking at things, we would basically use the floor as our reference point and align things by eyeball again to the floor. Well, that's kind of crude, and so it's an exciting system. In spine, we have very similar technologies that have evolved with both computer navigation to help us see in 3 dimensions the spine and allow us to insert implants in odd, funny positions in a much more reproducible way. And then we also have robotic technology that helps surgeons to implant the devices in a more accurate way. So it's a very similar thing, just a different space in the orthopedic world. So tell me a little bit about this Mako system.
Sure. Before getting into that, there's, when you talk about robotics, especially in the office, people don't have a great understanding of it. Everyone gets a little freaked out when you say, I'm going to help you use a robot or use a robot to help me with this surgery. And so, robots have been around for a long time in surgery, and probably the most well-known robot that people know about is the Da Vinci with general surgery and urology. And this is called a passive robot, where the surgeon is actually controlling everything and you're not getting any feedback from the robot itself. It completely revolutionized the field of general surgery and urology. I was looking the other day and actually saw that it was in 2012, 85% of prostatectomies were used by the Da Vinci. So it's completely changed several procedures in those fields. And when we talk about joint replacements, we're more talking about the semi-active and then the active robots. So a semi-active robot means that the surgeon still has complete control over the robot, but the robot's going to give us feedback. So it's not going to let us stray from, our deviation or deviate from anything that we planned prior. With the Mako itself here, you actually can't resect or cut bone deeper than 1/2 millimeter more than you planned. And it's also not going to let you go more than 1/2 millimeter on the inside or outside, so that this helps prevent any sort of surgical technical error that might have arrived previously.
So again, just to be clear for folks, the robot's not doing the surgery.
Right.
The robot is keeping, particularly the active robot, is helping the surgeon stay in their lane. They're trying to work the plan so that we don't harm things that we don't want to, we don't do things that we don't intend. And the active, as I understand it, is it'll actually block you from doing things. The semi-active will essentially warn you, but you could potentially blunder against the robot, so to speak.
Well, so the semi-active actually it has the bumper, so it won't let you deviate too far inside or outside, or too deep or too far in the back. The active is where you program it beforehand, and you come up with a plan, and you actually let the robot do all the work.
Okay.
And so that's how it's a little bit different there. And there's a few systems out there right now, but it's not mainstream yet, and not a lot of people are using because we don't necessarily have that technology yet. But that is something that in the future you might see. But currently, what most people use now when they talk about robotics, it's the semi-active. The surgeon has complete control, like we have here, but it's giving you feedback. It has haptics with it, so the machine will shut off if you're not going according to your plan.
And of course, the surgeon is the one that creates the plan.
Correct.
So,
Correct.
I mean, it's not like you're sitting drinking a cup of coffee in another room while the operation is happening with the robot, right?
Correct. And you'll plan this, and this is based off of the CT scan that you have gotten before surgery, and it's also based off of the registration you do intraoperatively.
So this system here, which is kind of the most up-to-date system, as I understand, how long have surgeons been using this on a regular basis?
It's been several years now. It's been in mainstream. I know people that have used it since 2012, so it's not something new that's been out there.
Right. You're not test driving unknown technology.
Right. This isn't the first person in Tennessee to do it. It's been there for a while.
Right. Okay. Well, in the interest of a little bit of time, because we have kind of a combo approach here, right? It's both the robotic surgery side plus a little bit of the navigation components.
Right. Correct.
So why don't you give us a little demo of kind of how you approach this and what it does for you to make your surgery presumably more effective and more precise.
Perfect. So if you step back a second and we talk about someone that comes into our office that has arthritic knee and has pain associated with that. And since we have a knee here, we'll talk about a knee replacement. The main reason why we're doing a knee replacement, first off, is to alleviate pain associated with arthritis. And that's how we can reliably do that. And then we start talking about robotics. And before going to surgery and you've decided on you want to have a robotic knee replacement, what we'll do is get a CT scan. And like I said before, it's so that we can get an anatomical 3D model of your knee, and this will help us template before the surgery and plan exact, component sizing and position. This gives us a better picture of what we need to do when we get in the operating.
How long does it take for you to template a patient out in your office?
So what we'll do is the CT scan. Generally, it takes about a day to schedule, and then it gets uploaded into the Mako system. And then from the Mako system there, it generates it, and it takes a few minutes to do. It doesn't take long to get this template performed. And then we go into the operating room, and the beginning of the case is just like a normal total knee replacement, where you expose the knee, and then you do what you have to do before having to make any sort of cuts for a knee replacement. Next, you would place these arrays that you can see right here and here. One's placed in the tibia or the shin bone, and then another one's placed in the femur. And what this does is it's actually projecting information from the leg to the computer screen right here in the sensors. And from this, we're able to get a few anatomical information, such as the hip center, so that we can obtain the information we need to have a successful knee. One of the number one rules in a knee replacement is to obtain a mechanical axis that's neutral. We do that by getting the hip center. That's one of the ways that's different than a manual knee or a non-robotic knee, is because we can reliably get that hip center and we can get the neutral mechanical axis from that.
And as I remember from old school, the hip lines up with the knee, lines up
Right.
with the ankle, right?
Right.
So it's a straight line basically from the middle of your hip to your knee to your ankle, right?
Right, and really all that means is it's making sure that the forces of your body weight going through your knee are equal on the inside and equal on the outside.
Yeah.
If it's too far inside, then it's not going to work. The implant's going to fail. If it's too far outside, the same thing, because the joint forces aren't balanced. And that's the whole goal, is to have an equal balance.
So he mentioned a reference frame. These guys here,
Yeah.
we talked about old school, we use the floor as a reference. This allows you to connect to the bone, and so the machine that's kind of out of your range here can see these. And so literally the leg can be in any position, and as long as the machine can see it, we know in 3 dimensions where the parts are. Okay.
And so once we have the sensors appropriately placed, and we've done a few of our checkpoints, then on the screen here, we'll actually have a roadmap of the femur and the tibia. And there's 40 dots that we will register within the system, and we use this tracker here, and we'll register 40 different dots in the system to confirm that our CT scan is actually what we're actually seeing, in real life here.
So that's live information on top of the CAT scan information that you've already received.
Right, and that just double checks it so that you don't just get a CT scan and it's different than what you're actually seeing intraoperatively. And once we've done that, now we've registered the knee along with our preoperative plan. And what we can do is actually bring the leg out
Kind of see here, that's what he's looking at in the operating room.
into extension here. And then this is when we start to do the dynamic ligament balancing. And this is what makes the Mako in robotics really unique and special, is because we can actually see how tight it is on the inside of the knee, which is at 13 millimeters, compared to that outside of the knee, which is at 15 to 16 millimeters right there. And so by stretching and giving a little bit of a valgus load here, I'm able to get that desired 18 millimeters, which is just the combined thickness of the implant with the plastic part, the polyethylene. And I can tell that I can reach that reliably with a gentle valgus stretch here. And then the same thing I'll do on the outside. And so this allows me to balance the knee extension, which is one of the principles of a knee replacement.
Why is knee balance, ligament balance important?
So one of where I did the fellowship at Insall Scott Kelly Institute, one of the guys who started the fellowship was John Insall, and he is widely known as one of the pioneers of knee arthroplasty. And he actually used to say that knee replacement is a soft tissue procedure. If you don't have a balanced knee on the inside and the outside, if you aren't tensioning the ligaments, your MCL and then your LCL, then the knee won't last very long. It's going to wear down on one side versus the other. And so with this, we're actually able to quantify it and give numbers that it is A, equal on both sides, and B, it's straight, it's neutral. You have a rectangular box there.
So again, trying to maximize longevity of the implant life, right?
Exactly.
Okay, cool.
And then also, whenever you have the knee out in full extension here, so if you can see limb flexion is 0 on the far right there, that you can actually quantify once again the alignment of your leg. So it says 5 degrees of varus. So people hear the word bow legged a lot, and that's essentially what that means right there. That quantifies it. It's 8 degrees of varus right there. This is something that we're able to correct with surgery to 0 to give you a straight looking leg. Then the next, once we've captured that information, the next thing we do is now we go to the flexion gap. Okay? So this is at almost 90 degrees of flexion. And once again, you get the same numbers, that 8 millimeters on the inside and the 12 to 13 millimeters on the outside. And so all this is telling us here is that it's a little tighter on the inside of your knee than the outside of the knee. Okay, now if I stretch it out, granted this is a sawbone model, I'm able to distract it a little bit here to get that 18, and then if I did the outside, I can get the 18 as well. But if we needed to do any sort of intraoperative adjustment on our preoperative planning, then we can do that very reliably here. And if Austin wants to click up and down on, if you capture on the inside, Austin, yeah, right there, and yeah, okay. What you can do is actually rotate the components to give you a bigger or a smaller gap on one side or the other. And you're able to do that very easily to get that perfect plane that you're trying to obtain.
So again, as compared to the way I learned how to do this was, we were all doing it by eyeball.
Right.
So we were testing flexion gap, we were testing the varus laxity, valgus laxity, but in the end of the day, it was, that feels pretty
Right.
good. And this is really just giving you a far more precise way of adjusting those three-dimensional factors, again, to maximize the implant life.
Right, exactly. And it takes out the variable of, you know, oh, this looks just perfect, you know, feeling. It's more of you have a number and you have more information to help you get the best results. And so essentially once you've finished balancing the knee, so you have equal flexion and extension gaps, and the ligaments are appropriately tensioned, then that's when, you know, you've made your plan, and that's when you can start talking about your bony cuts to fashion the knee to hold an implant.
Now, why do you have to cut the bone? I mean, for the audience here.
Yeah,
this is what part of the knee joint?
Right, so that's the femoral part of the knee right here.
So your thigh bone.
Yeah, your thigh bone. And if you can see here, there's multiple different lines or cuts in different directions. And this is essentially how we fashion your femur and how we make the femur accommodate this bone, this implant right here. And so we do multiple different cuts on the femur and the tibia to hold an implant.
You're essentially creating a puzzle piece
You are.
that locks in.
Right.
And the easiest thing to do with saws or whatnot is a straight line. So
Right, exactly.
That's why you do it that way.
Exactly. So we can actually show you that right here with the robot here. We're going to bring the robot in. As you can see,
I'll move out of the way in
it's
case
very
somebody
mobile
goes
here.
crazy.
Yep. Okay. Okay, so first we're going to register the femoral checkpoint here. And then here is actually the saw registration, okay?
So again, with that, you're telling the computer where all your various parts are.
Right, so what it's doing is it's telling the computer and the software, it's telling us that the saw is right here and it's going to bring us into the right direction for it. So if we will, I'm actually going to take the blade off here. Okay. And so what I'm going to do is I'm going to bring this in. Okay. If you can look on the screen here, you can actually see the saw blade and the cuts that we're going to make on this distal femoral cut. Okay? And you can see this is actually without a saw, but this is a demonstration of how it works intraoperatively. And just like that, you have a perfect distal femoral cut.
So it's a flat surface, and it's perpendicular to the line you want it at.
Yes.
And it's precise within how much?
1/2 millimeter.
So that's not even the width of the saw blade, essentially.
Right, so it is within 1/2 millimeter precise, and you don't deviate from that plan. The machine won't let you do it.
So you'd have to push against this big device, and it wouldn't let you move. It's too heavy.
Correct.
Too strong.
Correct. And so you essentially fashion all of your cuts that way, and you keep going through the different cuts on the screen, and this is how you make your knee replacement.
So this is the cut that he just made.
Right.
At the end of the femur. And then he go through these various angles to make the other cuts and just basically follow the saw and make sure that it's doing what it's supposed to do.
Absolutely, absolutely. And by the end of this, you've made all of your cuts for the femur right here and also the tibia, your shin bone, and now you're ready for trialing of the implant components, just like a normal knee replacement. But you've made the part that has the most variability, you have just eliminated that by using innovative technology.
Yeah, the human's the most inaccurate part of this whole team.
Right. Exactly.
Even though you're highly skilled, you're the most inaccurate.
Yeah.
And so you're using that technology
Right.
to up your game as far as accuracy. Very cool. Very cool.
Absolutely.
Now, is the robot technology and the navigation technology something that's done in other joints like the hip?
Yes, yeah, exactly. So with the hip, it's a little bit different, but the same concept, where you actually put a raise in, just like we have here in the femur and the tibia or the shin bone, and you do the same registration, you do the same CT scan, and you plane it the exact same way as you would a normal hip. But when it comes in, it's only a one reamer. You're taking out bone only one time, so it decreases soft tissue damage with a very, very accurate, leg length restoration, hip offset, tensioning of all your muscles, and it works great for the hip as well.
Now, obviously there's a number of different companies that make a number of different systems.
Right.
So there's not one company that makes all the systems. There's several out there.
Right.
We have a number of physicians who are using the Mako system currently in a variety of our offices, and I think you can probably find that on TOA.com. What's the Mako website?
You can just go to Stryker.com and
Stryker.com, STRYKER.com, and look in, I guess, TOA, and he can tell you the other physicians in your area. I'm not stealing from Dr. Carpenter's thunder because he's been kind enough to be here, but we do have other physicians who are up to snuff with this type of technology. Just a guess, we were talking before we came on air about what the data, how long is it going to take us to find the data to know, is this type of technology, is the juice worth the squeeze? And what I mean by that is, are we seeing better implant survival, better function, fewer predictable complications? How long do you think that might take, and how much data will that take?
Yeah, we saw it a few years ago with that. Just as we talked about before, we have changed a lot over the last 20 years with regards to hip implants and knee implants, and also with regards to the technique like robots. So we have to control the variables, and we have to look at this, and it's going to take about 20 years to get the long-term data on this. And we're at about 10 to 15 years now, and everything's looking promising, but we just don't have enough information at this point to say otherwise.
To say with absolute
certainty.
I mean, it's a great technology. It works well. It's
Right.
not investigational. It's not an experimental. You're not
Right.
the first, as you said, not the first person in Middle Tennessee that pulled this out of your garage to
Right.
do this. But we'll really know in another decade or so
Right.
the real longevity. Because really, in joint replacement, just like spine, because the body changes as we age,
Right.
I imagine that the longevity of an implant depends a little bit on how you age. So
Right.
if you get it in the best the first time around,
Yeah.
at least theoretically, you have the longest potential chance of survival with that implant.
The one thing we do know for certain about using devices such as the Mako and other navigation devices is it eliminates the outliers. So it eliminates the deviation of you look at an X-ray and you wonder how did it go in sideways type of situation. And every time you do this, it's very precise. You know exactly what you're getting on the other side, and so you're eliminating the deviations from the normal.
Awesome. I think that's probably a good place to stop. If y'all have any questions or comments live, please go down below and type in, and we can try to answer those. Will, do you have anything else to talk about briefly with regard to your interaction with the technologies that we've talked about thus far? What other things might be out there? And then obviously we're kind of creating a situation of, if you've got more to talk about, we'll bring you back and we can talk about other stuff.
Yeah, I mean, there's always new innovation and development, especially in joint replacements. And as we learn more and more about, what a person's normal kinematics is, which is just how, I function, my knees function different than, your knees function. And so that's what we're seeing kind of on the forefront of knee replacements and hip replacements right now. Is everyone's different, not everyone's built the same. And so once we get more information on that type of information about how we can make this to where it's not, your knee is different than my knee, then we'll be able to really hone in on, having that 100% success rate that everyone's trying to achieve.
Awesome. Now, we've talked about TOA.com as a good resource. Do you have any additional ways to get into your world? I think you have a website that,
I do.
That might explain this in a little bit more depth. What's that?
I do. So I have a website where I created for patients that have, they want more information about kind of the procedures that I do, as well as robotics and some of the other technologies out there, and along with kind of frequently asked questions about, these type of procedures. And if you go to www.carpenter, carpenternd.com, you'll be able to have answers to some of the questions that you might have.
Awesome. That's great. That's great. So, again, I think we'll wrap it up today. Will, thanks so much. This was great. Please, if you have another topic, I'd love to bring you back, because I think this kind of stuff, it floats my boat.
Yeah,
I think it makes a lot of, it's in the news, it's in and around, people know about it more than probably we really understand. And so it's exciting to see this. I thank the Stryker gentlemen very much for taking their time and their technology and bringing it here. This is no small feat to get all this stuff in our office. So while I'm not selling Stryker equipment, I really appreciate you guys doing that. Really means a lot. For those of you out there, if you think of any topics that you're interested in, please go comment below. Remember that our videos are archived on Facebook. They're also archived in the TOA.com Media Center, and they're also archived in our YouTube channel. So you can go back and look at any of our Facebook Live, the Dr. Zen videos. We've had a pretty good response with people. It seems to be a popular topic. Maybe it gets people a little entertainment and information during their lunch break. I don't know. But in any event, if you have any ideas or interest, please let us know. For all of you out there, as I said last time and the time before, for me, for us, for healthcare workers, the COVID-19 situation is real. There's still a lot we don't know. There's no right or wrong answer at this point. We've got to keep the politics out of it, and medical folks kind of think in common sense ways. If we can do anything possible to minimize the risk, we're going to recommend that. So please follow the CDC guidelines to protect yourself and particularly protect other people in your family or circle of friends. Anyway, with that said, I hope everybody has a great weekend, and it's going to be hot as can be this weekend, so be careful, drink lots of water, and go out there and live your best life.